All right, everybody, we're going to go ahead and get started. It's a couple minutes after. I want to be mindful of everybody's time. Hopefully we'll have some more people hop on here. So I'll keep an eye on that as we go. But thank you for everybody hopping on. We really appreciate it. We got a full session again. We've got a couple of cases as well as a didactic presentation. So it'll be just kind of like last time, the first session. A little bit different from the first session. We're going to ask everybody to put their information into the chat for introductions. It's kind of plays twofold. One, saves us a little bit of time going around the Hollywood Squares, especially when we have a full session. And then also get you a little bit more acclimated to using the chat feature if you can't unmute. So go ahead and put your name and your email and your organization for your introduction. We'll just keep it pretty simple. Go ahead and drop that in the chat. If you do not know where the chat button is, if you look down on the toolbar that's kind of at the bottom of Zoom, it's going to be right there, third in, right next to the share screen button. But go ahead and put that in. Thank you, Chris. Follow Chris's lead, and we'll be all set. I think we're going to start with the cases. Joy, did you want to lead off and go first? Or Jess, how did you want to go? I'm sorry, you were muted. I didn't hear the answer there for a second.
Yeah, I'll go ahead and start.
Okay, all right. Okay. All right, let me pull up the cases and you can go ahead and get started.
Can I pull them up on my side of things or?
Oh, yeah, sure. Yeah.
Okay.
Yeah, give me 1 second. And okay, you should be good to go.
All right, can you see my screen?
Not yet.
Not yet, so let's go to Zoom.
Okay.
Then share, come to that. No, the site. Go to share at the bottom of the screen. You should have share screen. Now pick yours.
Gotcha.
There you go.
Okay.
There we go.
All right, sorry about that.
That's okay.
Not very technologically advanced. So I'm gonna start with a case. So our focus today is highly bioavailable antibiotics, more for the PO round. So I picked out a couple cases where that came into play. So my first patient is a 50-year-old female with a bone and joint infection. So like our previous cases, you know, the diagnosis isn't really in question here. So she was a 50-year-old, had a chronically infected right total hip arthroplasty. She was admitted for a planned insertion of an articulating antibiotic spacer. So resection and insertion of a spacer. Her aspirate prior to admission, as well as her OR culture, were both positive for MSSA. So she was started on cefazolin, a PICC line was placed, and the plan was for her to do a 6-week course of cefazolin, but roughly 2 to 3 weeks into that course, she developed an itchy rash. So I already kind of went through her past medical history, as well as medications wise. We have these listed. I'll kind of draw your attention to the Effexor and Flexeril to come back to. Another thing I wanted to mention was that she did have a known allergy to Keflex, which we'll come back to as well. In terms of her pertinent social history, so she was local. She was going to infuse her own antibiotic and just come to ID clinic for her PICC dressing changes and her labs. So when we look at her labs and things, you can see that if the patient hadn't reached out to me about her rash, I would have had no idea. Her labs looked great. You know, her white count was normal. She didn't have a significant eosinophilia. Her creatinine was normal. There was no transaminitis. Her CRP was getting better. All good markers that the cefazolin was working. And as I mentioned, you know, it wasn't a question about if we were on the right treatment. It was, what do we do now that we're 3 weeks in and we have a drug rash? So the questions that were kind of, sorry. The questions that were proposed to us. So, okay, we're 3 weeks in, can we go to a PO option, or Do we go ahead to another IV option? And then she has a drug rash. Do I need to bring her into the hospital, or is this something I can actually safely manage at home with her at home? On that, I have some pictures. So this is the patient's rash. She kind of described it as red and itchy.
We do not see the pictures. You might have to reshare your screen if you're sharing a different document.
Stop share. Stop share up at the top.
Yeah.
The second line.
Oh, I
Yeah,
see that.
there you go.
Okay.
Now share again.
I'm sorry, I didn't realize that.
Now pick the picture.
Okay,
There you go.
gotcha.
There
Sorry.
you go. Now they can.
All right, so this is the patient's arm, and you can see kind of this red splotchy rash. She said it started on her trunk and then spread. It's very morbilliform is the word they use. This is really classic. So it's very trunk and then kind of spreads out. Now, you can also have more of like an urticarial picture. This is not the same patient, but probably the cutest patient I've taken care of recently who had a drug rash on a cephalosporin. And you can see hers looks more like spots. And the pediatrician had reached out to me and said, you know, is this a virus or is this the drug? And I was like, well, I mean, it could be a virus, but she's 2 weeks into this antibiotic course. She's kind of right at the right time. Let's stop it. I reached out to Peds ID here, who of course helped us kind of take care of this patient and get her adjusted. One of the biggest parts about my job is like knowing your resources. So shout out to our enterprise antimicrobial stewardship service. So if you go to your Epic home screen and click here, you have all these like awesome resources that can be really helpful with things like this. So my first question when I was reviewing this patient was like, okay, so she had a rash on Keflex. Did we maybe miss that? Like she was on cefazolin. Was that okay? So, you know, you go down and you find your cephalexin, and you go across and find your cefazolin. So no, it was completely appropriate to consider a cephalosporin because they have different side chains. This is an awesome resource that I use a lot when I'm going from cephalosporin to another cephalosporin, so that we're not always trying to go from something a little bit more narrow spectrum to something more broad. So our first question was, we didn't create the problem, which is always good. The next question was, okay, do we go from an IV to an IV? And that was really where we were considering. So we're treating Staph aureus. Can we just go to daptomycin? You were on last week. You know, that's my favorite antibiotic. It's once a day. It's usually a push. It's awesome. We ran that through the patient's insurance. It was really expensive. We then even thought about bank, which was actually also very expensive, surprisingly. And that's when we pulled up our other resource from Stewardship, which was, okay, can we maybe consider an option of an antibiotic by mouth? I'll try not to take too much of Drew's topic away. So like I said, so she has an allergy to Keflex. Okay, what about cefadroxil? All right, that might be an option. Let me go back up to my chart. We know she's got an allergy to Keflex and cefazolin. And then, of course, when you look at this chart, it doesn't mention cefadroxil. So if you're like me and have the awesome resource of a bunch of ID pharmacists, you can ask them again, okay, is there cross reaction between Keflex to cefadroxil or cefazolin to cefadroxil? And Dr. Amy Spiegelmeyer, who I always seem to ask this question, I think has it memorized and always reminds me, yes, you can't use Keflex, an allergy to Keflex, because they have similar R1 side chains to cefadroxil. So, okay, cross that one out. Okay, what about Bactrim? We look at how available it is to the body. It's really good at these high doses. problem is, high dose Bactrim, that can be hard to get through. And if you're on an ACE or an ARB like this patient was, you have that risk of hyperkalemia. So I kind of was like, okay, I'll put like half a star next to that. Now let me go to my other favorite antibiotic, which is linezolid. So when we look at this percent, 100% bioavailable, can I get the patient through 3 weeks of linezolid? That's when I go back and look at the patient's medicines. For this patient, she was on Effexor and Flexeril as needed Flexeril. I asked her if she would hold it. She said, yeah, I don't take it very often. I cautioned her about serotonin syndrome. The only other additional caveat I want to mention was when you looked at the patient's labs, her platelets were very good, nice and stable, like 300 plus. That is sometimes what you run into is the low platelets, especially after 2 weeks. I knew that she would be fine to push the bar a little bit more with that 3-week linezolid course. So that was kind of the direction we decided to go forward with. That was my first quick case. Any questions?
As a reminder, feel free to unmute or use the chat to ask any questions or if you have any comments.
Right.
Is one comment I was going to say about the linezolid is that we have had many patients now that we've treated with nearly 6 weeks or 6 weeks of linezolid that have done well. So even in a patient with a little bit lower platelets, that's why we have our preference, like OPAT and COpAT, COpAT for monitoring on oral antibiotics, that we found that a lot of patients do quite well and tolerate it.
Yeah, absolutely. Kind of what Joy was saying, if I go here and I want to do my second case, I go back, share my screen. I can then click on my second case. Is that correct?
Correct.
Okay. Okay, can you see my second case? Or do I need to?
I think you might need to stop share and then do it again because it's probably.
Yeah, I think it's the old one. Yeah, this or the
Okay.
Now you'll make it.
Okay, and it was. Okay. So Julie brought up a really good point, and I'll try and bring it up to this patient as well about linezolid and maybe considering a longer course. So this is a 63-year-old patient with diabetes, coronary artery disease, and peripheral neuropathy with a diabetic foot infection and what I would describe as low-grade MRSA bacteremia. So came in with acute worsening on the day of admission, had some surrounding erythema. Blood cultures were 1 set was positive for MRSA, 1 was negative. And had a CT scan that really confirmed he had osteomyelitis of his 5th metatarsal. So underwent an IND. So this was not, like amputation or something like that. OR cultures group MRSA and group B strep. Repeat blood cultures at 48 hours were negative. The ID team saw him, recommended a 6-week course of daptomycin, ceftriaxone, and Flagyl. He was discharged with home health, plans to do home antibiotics. 2 days after discharge, I got a message that his PICC line was measuring out. We brought him into clinic. It was no longer central, so it had to be replaced. And then the next day, I got another message that it was completely gone. So he had lost his PICC line twice. For the sake of time, I'll just kind of go through this. So again, our big issue now is that we have a patient discharged on home IV antibiotics. It doesn't seem like it's working. I called him and he kind of agreed with this. He said that the plan had been his sister was going to help administer antibiotics, but it was really difficult for her to. And he just did not think IV was kind of where, what he was able to do. His labs really had showed pretty stable findings. His CRP, when I talked to him, had already gotten a lot better. It was in the 40s. So now I have this dilemma where I have a patient who's lost his PICC line, and I'm thinking, okay, he's had MRSA bacteremia, he's had a diabetic foot infection. Is there a way I can get around a readmission safely? So what I did for this patient is what I call HPAT, which is a hybrid IV to PO regimen. I had considered linezolid to replace, vancomycin and treat the MRSA bacteremia. However, the thing that led me away from this was his medications. He had multiple serotonin medicines. The other thing was his platelets. They were already kind of on the lower side of normal. I was worried that I couldn't get him through 4 weeks of linezolid, even with good discussion of serotonin syndrome with his other medicines. Other thing is I kind of wanted to keep an eye on him. So what I proposed was that we do Dalvance and then switch him to Augmentin 875, 125 BID. So I still had good polymicrobial coverage, and I was still treating his MRSA bacteremia appropriately based on new literature. And he did great. CRP normalized, and he tolerated it both really well. And it gave me the opportunity to kind of check in on him in clinic when he was getting his Dalvance to make sure that we were still on the right track.
4 weeks of Dalvance?
So I actually did 2 doses of Dalvance. Yeah, there is some literature that says maybe the 3-dose regimen is preferred for especially when you're thinking of like osteomyelitis. What I used was that his CRP normalized, and I was already having a little trouble getting him into clinic. So I thought, let's do the 2 doses and keep our fingers crossed. But yeah.
Did you have any trouble with the logistics of getting Dalvance?
So that's a good question. So why we don't use Dalvance more in OPAT is really the expense. It does need an authorization. I brought this patient into ID clinic for the doses, which is pretty much the only way I've been able to get Dalvance to other patients. I had one patient who received it through home health, but that was like at home, that was kind of a special circumstance. If I can do this now. Okay, so stop sharing. All right, 3rd time's a charm.
Jay, I'm gonna let you go ahead and, well, are there any questions?
Yeah. Do you need me to share, Joy, your cases?
Yes.
All right,
And
sure.
share them and run the show. The first one I had was 321.
Okay. Yep. All righty, should be good to go.
Thank you.
Mhm.
These are 2 COpAT cases. So I'm gonna start out here. So these are an endovascular infection. And I'm proposing a COpAT regimen of cephodroxil 1 gram twice a day. And I'll get into this a little bit later, but it has good MSSA coverage and high, greater than 90% bioavailability. So moving on to the patient's history, the patient presented with fever, generalized weakness, and body aches, blood cultures through MSSA in multiple sets with clearance of bacteremia achieved on August 6th. CT chest imaging showed septic pulmonary emboli, and a transesophageal echocardiogram showed a ventricular septal defect, so a VSD. An adult congenital cardiology service evaluated the patient and recommended interval VSD closure on an elective basis after discharge. And at the time the patient was evaluated, he was receiving cefazolin for MSSA. So moving on to the patient's medical and surgical history, he did have a known history of a heart murmur. During his hospitalization, he had newly diagnosed diabetes. He was morbidly obese and had a food disorder, just took some medications for that. So his medications here, we have buspirone, metformin that was started on discharge, omeprazole, sertraline, and then loperamide or Imodium as needed for some diarrhea. So moving on here, he did have an allergy to penicillin. Azithromycin had a side effect of diarrhea. For social history, lived with his wife, no history of alcohol, tobacco, or drug use, and he was employed making cabinets. You can scroll down. On physical exam, when we met him, he was afebrile, was ill earlier in the hospitalization with the temperature reaching almost 40 degrees Celsius. He looked well, unlabored respirations, and he did have a grade 4 out of 6 polysystolic murmur at the left sternal border. Kind of moving on to his labs, his CRP earlier in his hospital course was very high, so around 440. At the time we saw him, his white blood cell count was normal. The rest of his labs were pretty much unremarkable. CRP had decreased to 34. And then for his microbiology and results, again, he had multiple blood cultures that grew MSSA with his blood cultures cleared on August 6th, and also had a urine culture that when he came in, that had some MSSA that was from the hematologist MSSA bacteremia. So again, his imaging, we already went through this a little bit, but his transesophageal echocardiogram showed a VSD in the region of the outflow or supracrustal septum. No severe valvular abnormality and no vegetations were visualized around the VSD or on the anterior right ventricle wall. When we met him, he had a peripheral IV and not yet gotten a PIC. So main questions about this case, and to generate some discussion from the group as well, is, how would you summarize this case? What would be, him in a one-sentence summary or the diagnosis? Anyone? So we felt that he had an MSSA VSD associated endocarditis with septic pulmonary emboli. And the teaching point here is the VSD, you have blood flow kind of going from the left ventricle to the right ventricle. And the most common location for the endocarditis is on the right ventricular wall. And on the transesophageal echocardiogram, there were no vegetations visualized because at this point on the CT of the chest and how he presented clinically, he had septic pulmonary emboli. So it goes from the right ventricle through the pulmonic valve to the lungs. So the VSD-associated endocarditis presents as a right-sided endocarditis. And so that's how we summarized his case. The second question, is early intravenous to oral antimicrobial transition possible? So this patient has an endovascular infection. Would you treat him with oral antibiotics? Anybody?
Don't be shy. Use that chat or unmute.
I know I would have been more comfortable if it was right-sided endocarditis, maybe in a more of a typical right-sided endocarditis.
valve,
Yeah,
yeah.
tricuspid valve, maybe a patient with some underlying injection drug use versus a patient with a VSD. But this would be one I would ask you all about before I would do it myself, to be honest. Yeah.
We did treat him with oral antibiotics. He ended up getting oral antibiotics for the majority of his course. I think the last 36 days of a total 42-day antimicrobial course. Our thought process was we have literature that oral antibiotics are effective in the case of effective in the case of infective endocarditis. So one reference we go back to is the OPAT trial, and that was published in the New England Journal of Medicine back in 2019. And that was a study that in medically stable patients, and they actually looked at left-sided endocarditis from gram-positive organisms, but that after a minimum of 10 days, those patients, they transitioned to oral antibiotics. They did very well. So it was a large clinical trial, and we've had success in our COpAT program treating patients with endocarditis with oral antibiotics. In his case, we had given him the option. His CRP actually normalized, came down to around before the end of 4 weeks of treatment, and he had already gotten his full supply of antimicrobial therapy and wanted the full 6-week duration. He had a VSD closure at that point planned the following month. So, and then the third question here is, do you agree with using cephodroxil and why? And agree with cephodroxil. One teaching point here is in endovascular infections, as well as our bone and joint infections. We've been doing the higher dose of cephodroxil instead of the typical cephodroxil 500 milligrams twice a day. It's 1 gram twice a day. And the why is, again, it's good MSSA coverage. It's in the same class of cephalosporins as the cephalexin, but it's dosed less frequently at BID, and it has high bioavailability greater than 90%. So this patient did very well, actually is back to work, and then now awaiting his VSD closure. Any other discussion on? No. All right. Next case I have, it's labeled 331, but I'm not sure. Okay. You got it. You got it, Jay. Perfect. New number, 324. Okay. So sticking with the endovascular theme, this is another endovascular infection where we're proposing COpAT. So starting out with which antimicrobial therapy and why. Levofloxacin at the higher dose of 750 milligrams once daily. And the thought process here was this was a patient that ultimately had a streptococcal infection with some increased MICs or intermediate resistance to intermediate susceptibility to ampicillin penicillin. And so levofloxacin has good streptococcal coverage, and it has high bioavailability greater than 99%. So moving on to the patient's history, this patient presented with worsening shortness of breath and fatigue. He was found to have elevated troponin, subsequently developed fever. When blood cultures were checked, it grew as Streptococcus cristatus, which is a Viridans group Streptococcus. Bacteremia cleared quickly the following day, and he had a transesophageal echocardiogram that showed a bicuspid aortic valve with severe aortic stenosis and regurgitation with flail non-coronary cusps and vegetations, measuring about 1.4 and 1.5 centimeters of greatest dimension. The patient ended up undergoing mechanical aortic valve replacement on August 25th, and operative cultures were negative. Surgical pathology was consistent with infective endocarditis, and during evaluation, he was receiving ceftriaxone. So moving on to his medical surgical history, he did have a prior diagnosis of severe aortic stenosis. The bicuspid aortic valve was a new diagnosis, had some coronary artery disease, hypertension, hyperlipidemia, and some chronic back pain. And medications, in this case, aren't too contributory. I think he was receiving warfarin, and this was after his mechanical aortic valve replacement. He had no known allergies. And he lived with his wife. Again, no alcohol, tobacco, there was significant or illicit drug use, and he worked at home making maps on his computer. So on physical exam, he was afebrile. And again, he was febrile earlier in his hospital course with temperature around 39 degrees Celsius. He looked well when he was evaluated, no trouble breathing. He needed to have a mid-systolic click with no murmur. And again, this was post-operatively after his mechanical aortic valve replacement. His sternotomy incision was intact and healing. So when he first presented, moving on to his labs, his white blood cell count was mildly elevated. At the time we evaluated him, it had normalized. And again, labs overall looked pretty unremarkable. I think there was a mildly elevated alkaline phosphatase. And INR here, again, he was on warfarin at this point, was 2.7. CRP hadn't been checked. Moving on to microbiology and pathology. So blood cultures, 2 sets on August 18th through Streptococcus cristatus. He did have a mildly elevated increase or MIC to ampicillin and penicillin, resulting in intermediate susceptibility. Ceftriaxone was susceptible and levofloxacin susceptible. And 4 to 4 bottles and cleared his bacteremia the following day. Operative cultures on August 25th had no growth, and then surgical pathology, again, from the aortic valve resection was consistent with infective endocarditis. Kind of moving on to his imaging, I already talked through this. The TEE showed a bicuspid aortic valve, severe aortic stenosis and regurgitation, and then a couple of vegetations. And at the time we evaluated him, he had a peripheral IV line. So kind of similar questions, keeping it parallel with the other case. How would you summarize his case? Kind of just putting him together, what would be the diagnosis? Anybody in the audience? Sorry.
Let me just summarize. So I would summarize him as native bicuspid aortic valve endocarditis with strep, status post valve replacement with a penicillin MIC in the intermediate range.
Great. So is early intravenous to oral antimicrobial therapy transition a possibility in this patient? How would anybody that's participating treat him?
I think
Right.
if your goal is to get us more comfortable with the oral regimen, you presented the harder choice first.
Yeah,
You know,
Yeah.
So once you are comfortable with the VSD patient being treated for MSSA, then I think you become a little more comfortable treating this patient with the strep.
I probably would have kind of stuck with my hybrid regimen,
Yeah.
maybe my couple weeks of
IV.
IV and a couple weeks of PO. So interesting to think about. I know your next question, do you agree with using levofloxacin? Was there a reason to kind of go with that for quinolone versus an alternative, or just based on sensitivities, or?
Yeah, just based on susceptibility testing. So with that increased MICs to the ampicillin, penicillin, which was levofloxacin, which has great streptococcal coverage. We know it's susceptible, and we treat it with the higher dose of 750 milligrams once a day, and it has 99% bioavailability, so it reaches high blood levels. And he ended up getting levofloxacin, I think, for the last 26 days of a 28-day course. Treated him for a 4-week course, and he did very well. CRP normalized, and actually had a
Yeah.
telephone visit with Dr. Smart
Today,
Yeah.
so he's the one I had a chance to follow up on today. Done extremely well. Off his antibiotics for about 2.5 to 3 weeks. Had his follow up with surgery and recuperating well from what was an open valve replacement procedure. So I think the question about quinolone versus say cephalosporin is a valid one to ask. My own bias is probably tilted a bit more towards the highly orally bioavailable drugs like the quinolones, the linazolids, and now cefadroxil. So that might have been a question.
An endovascular
Yes.
infection.
Yeah.
My other question would be, so we all know the black box warning for fluoroquinolone. Sometimes I at least find myself counseling patients more on PO antibiotics than IV antibiotics, like what to watch out for. But how do you kind of walk a patient through that when they're going to be on fluoroquinolones for a long
Extended
time?
period
Yeah.
of time. So yeah. So I certainly do bring up some of the challenges with quinolones, and I present it as a trade-off. You can certainly go the IV route, get a PICC line, and that has its own challenges. The quinolones in general are reasonably well tolerated, but have certain conditions. So I've started focusing a bit more on the tendinopathy. I'll ask them questions about their, does it hurt in your ankle? Those kind of much more directed questions. So that's the big one that I've, especially when we use it for anything more than 2 to 3 weeks, been a bit more focused on, quinolone toxicity. I think any antimicrobial that once we start going beyond the 2 to 3 week mark, whether IV or PO, will have the potential for an increased toxicity, and the programs are what help us monitor it, whether it's the IV or the PO, the weekly follow-up, touch base, phone calls and labs help us with making sure that we take them through safely.
Thank you so much, Joy and Jess. Those were great cases. Appreciate your time putting those together and then presenting them today. We are going to, I guess, switch gears if there aren't any other comments to Drew's presentation. If there aren't any, I'll give it a minute here to make sure. All right, Drew, if you can go ahead and share your screen, you should have that ability, and go ahead and take it away with your talk.
Yeah, sure. Thank you all for the introduction with cases. I'll be touching on a few of the things that were discussed in those couple of OPAT and COPAT cases. You all see my screen okay?
Yes.
Okay, excellent.
Oh, actually, we see your presenter notes. If you, just swap it there. There you go. All right. Looking good.
I'm just going to touch a little bit more on the concept of bioavailability in oral antibiotics, maybe some misconceptions or things we can clarify that'll make practitioners more comfortable using them in a variety of different settings. So really our only objective today is to recognize differences in oral bioavailability of antimicrobials. And I'll start right off with a couple of definitions that I think it's worth differentiating between. The first is the concept of absorption versus bioavailability. Absorption simply refers to the movement of drug into the
I think we might have lost Drew there for a second. Drew, if you can hear us, you are frozen at the moment.
And so the idea that
Hey Drew,
yeah.
did you froze for like, I don't know, it felt like a long time, but it wasn't. It was like 15 seconds. Could you maybe start with that slide again?
Yeah, sure. Sorry, I did see my connection dropped in and then back out.
Okay. If you feel it's weak, go ahead and just turn your camera off. That sometimes will help make it a little bit steady. So if you see that again, just go ahead and do it. We'll know why.
Okay, sounds good. So I was just I was going through definitions of absorption and bioavailability. Absorption refers to movement of drug into the bloodstream after oral administration. In our case, this is different from bioavailability. So regardless of how bioavailable a drug is, whether it has exceptionally high bioavailability or lower bioavailability, that is rendered kind of moot if you don't understand a patient's ability to absorb the drug. So do they have a functioning GI tract? Are we making sure they're not taking any medications that could potentially prohibit absorption of the drug? And once we are assured of those things, we can kind of get into discussions about bioavailability, which simply is just the fraction or percentage of drug which enters systemic circulation after oral administration. So of the drug that was ingested by the patient, what percentage of active drug actually reaches systemic circulation? Some people may also describe it as, say we give a similar or an equivalent dose of IV therapy. What is the expected equivalent amount that an oral dosage form of the same drug could provide? And so with those two concepts in mind, other things, like I'd mentioned, we should consider are, should things be taken with or without food? So a lot of this, a couple of these things kind of play more on the absorption side. High-fat meals may increase absorption of certain antibiotics or other antimicrobials. whereas taking things with food or say acid suppressants, that gets onto the effective co-administration piece, may inhibit absorption and thus limit bioavailability of the drug. So I mentioned briefly, a functional digestive tract, something that I would encourage anyone who has the availability or opportunity to ask.
We lost you again there, Drew. Give me a second to come back.
You'd consider.
Hey, Drew, you dropped out again. Yeah, perfect.
Yeah.
Go ahead.
Okay.
Yeah,
I stopped my video.
Yeah, just recap that just a little bit there before you move on.
Yeah. So kind of talking about the functional digestive tract, we already touched on with or without food and effective co-administration. We'll see some examples in the coming slides, but patients may, for whatever reason, have only a portion of their GI tract available for drug absorption. Maybe part of it was removed for a metastatic or purpose, or they have direct injury, say in a trauma that resulted in removal or dysfunction of a portion of the GI tract. Different drugs, really based on their acid and base properties, are absorbed at different stages of the GI tract. And so obviously, if that particular portion isn't present, then there is some concern as to whether or not the drug will absorb appropriately. So anytime you may have a question about that information is usually pretty readily available on a lot of tertiary resources, but certainly primary literature can be looked at too. Another key concept is dose optimization. So obviously oral antibiotics and other antimicrobials have variable bioavailability. So sometimes we can overcome a lower oral bioavailability by optimizing the dose of certain antimicrobials versus, say, the dose of IV therapy we would administer if the same drug was used. And lastly is desired site of action. This is a really key point. I'll only bring it up here, but a good example is say macrobid, a drug that's highly oral bioavailable or highly bioavailable, but only really concentrates in the bladder. And so we wouldn't use it for any other systemic infection, for example. This is also something we keep in mind with IV antimicrobials as well. So how I'll present the rest of what I wanted to talk about today is sort of in a stepwise fashion, looking at different classes of antimicrobials and then just highlighting some key important points to think about each of these. The first is the group of penicillins. I selected really antibiotics and other agents that I found were more relevant or came up more frequently in clinical practice. So this isn't an all-inclusive presentation on every oral antibiotic out there. But when thinking about our commonly used penicillins, those are really things like amoxicillin, penicillin, and amoxicillin clavulanate or augmentin. So as you can see, they all have kind of a bioavailability and oral bioavailability about 60 to 75% or say. And which is decent compared to other beta lactams we'll look at. But it's certainly something to keep in mind when dosing these medications for, say, higher inoculum infection. The best example or an example I might give is, utilizing a high dose of amoxicillin, 1,000 milligrams TID versus lower doses for higher inoculum infection, or say when you're treating a partial course of a bloodstream infection or even more serious infection. The next group is our cephalosporins. So I picked out a handful of cephalosporins that come up for us routinely in day-to-day practice. As you can see, our two first generation options, cephalexin and cefadroxil, have excellent oral bioavailability, upwards of over 90%, and can be administered without regard to dietary intake. Compare that to these other agents. So cefuroxime, for example, it's a pretty commonly used agent, say in the case of community-acquired pneumonia. We don't use it a ton, I would say, in a lot of our COpAT patients where we're trying to target these really severe infections like endocarditis or bone and joint infections, where we would largely prefer something like cefadroxil or Keflex where possible. You can see that, and this is the first example that pops up here, but the tablet formulation of cefuroxime should be taken with food, as that can increase absorption versus the suspension that's available. Say you have a patient who can't tolerate a tablet or a solid dosage form, or a pediatric patient, the suspension is advised to be administered without food. I highlighted this next antibiotic because it's kind of a pet peeve of many of ours in the ID pharmacy group, but Ceftonir is an agent that has very poor oral bioavailability regardless of what dosage form you use. And our recommendation in most cases, where possible, is to avoid this antimicrobial altogether, because we have this other list that I've provided here of alternative options, including cefpodoxime, that has better bioavailability than Ceftonir. Even with that said, cefpodoxime or Banton only has about 50% oral bioavailability. Something to consider, and alluding to a definition or what I talked about earlier with, comparing the amount of, say, an equivalent IV dose of drug to an oral agent, to keep in mind is that, most of these agents on this slide don't have equivalent IV formulation, so they're only available orally. So where you see that they have lower bioavailability, it's kind of, we can't necessarily compare that to a specific IV agent in terms of what dose of that only orally available antibiotic looks like compared to, say, cefuroxime, which is available both IV and PO. So just something else to keep in mind. And I can clarify that later on if anyone has any questions with other examples. Next, I wanted to move on to our fluoroquinolones. They are agents that we use frequently in our COpAT program, in large part thanks to their high oral bioavailability and their demonstrated efficacy in treating deep-seated infection with recent literature publications. They all are relatively highly bioavailable. Ciprofloxacin comes in around 70%, whereas Levaquin and moxifloxacin exceed 90% bioavailability. Fluoroquinolones, as well as a number of other antibiotics I'll talk about in the following slides, should avoid co-administration with any cation containing product. So these would be things like antacids, a lot of multivitamins, for example, as those can bind the drug, inhibit absorption, and thus decrease the bioavailability of the drug. One thing I did want to highlight, though, was the case of ciprofloxacin. So as you saw in the previous slide, it's not as readily bioavailable as the other oral agents that I mentioned. One of the ways we address this is by that concept of dose optimization. So a typical dose of ciprofloxacin when administered IV might be 400 milligrams twice daily or 400 milligrams thrice daily, depending on the indication, type of organism you're targeting. You can see the PO equivalences are actually doses higher than those IV doses. So we would use to equivalate 400 milligrams IV twice a day, 500 milligrams of oral Cipro twice daily. If you do the quick math, you can probably do it in your head just by looking at the screen, but 400 milligrams is about 80% of that 500 milligram dose. So we're nearly completely negating the lower bioavailability of ciprofloxacin relative to its IV dosage form by optimizing the dose. And the same can be said with the higher oral dose of ciprofloxacin of 750 PO twice daily. Next are a couple of slides about miscellaneous antibiotics. Doxycycline and minocycline have high bioavailability, upwards of 70% or greater. another agent we would consider avoiding co-administration with cations. I do want to highlight azithromycin's particularly poor bioavailability. We've kind of seen it fall out of favor for many reasons recently, especially in the treatment of kind of uncomplicated upper respiratory tract infections attributed to our respiratory gram-negatives like H. flu, for example, or strep pneumo, because of higher incidence of resistance to that particular agent. But it's also not the most bioavailable drug either. Compared to something like trimethoprim sulfamethoxazole or metronidazole, where we usually feel comfortable, interchanging equally between IV and oral formulations because of high oral bioavailability. This next slide details a couple of gram-positive agents, or agents we use routinely in gram-positive infections: clindamycin, linezolid, which is frequently a component of our COpAT regimens, in large part, again, thanks to high oral bioavailability. It can be administered with or without food. The only caveat that we usually recommend patients avoid taking it alongside tyramine-containing foods. So this is after we've assessed, platelet count, like Dr. Johnson had discussed, concomitant medications that have serotonergic activity, which was the topic of our last echo presentation. But these kind of foods would be things like red wines, chocolates, aged cheeses, fermented things like especially darker beers, as an example. The next couple slides are looking at oral antifungals and antivirals. So I recall in pharmacy school, and I still have to go back and look at this information from time to time when I'm using these agents for our patients. They have different dosage forms, and depending on which dosage form you use, even which oral dosage form you use, bioavailability can vary. Fluconazole is pretty simple in that it's highly orally bioavailable, but we run into differences, say, with itraconazole, where bioavailability is quite variable. Solution of itraconazole is often, or is known to be, more bioavailable than available capsules, but we can run into issues with insurance authorization with itraconazole solution, or say we require, or the patient may need a large volume of the solution in order to meet their dosing needs. And thus, itraconazole, fluoroconazole, and posaconazole all can be monitored via therapeutic drug monitoring to assess for adequate serum levels, more routinely to make sure we're not exceeding a toxic serum concentration, as compared to other things we monitor drug levels for, like vancomycin, where we know there's more data with clinical outcomes. But again, that technology is out there and is recommended in the case of administration of kind of those three antifungals. And lastly are the oral antivirals. You can see, especially in the case of acyclovir, these agents don't have the greatest oral bioavailability. If you compare dosing of IV and oral options, they'll vary quite significantly because of this decrease in bioavailability. So it's always a good idea, if you're considering stepping a patient down or transitioning to a maintenance portion of a course with an oral antiviral, you're prescribing the correct dose and using the correct dose relative to an IV formulation that the patient may have been receiving. I just wanted to point out that a lot of this information, as I alluded to earlier, is available at our tertiary resources. So whether or not you're listening and a part of the WVU Medicine Health System or not, you likely have access to one or many of these. The one that we routinely use is LexiComp. And I pull a lot of information as well from antimicrobial textbooks out there. So the particular one that I was looking at for preparation in this presentation was Kusser's use of antibiotics, which has a lot of information just beyond pharmacology of drugs, if you're interested in the really nitty-gritty details of antimicrobials. That was quite a bit to go through, but I'm happy to answer any questions anyone has about any of the content I presented today.
Thank you, Drew. Really appreciate it. Sorry you had some technical issues, but it went through fine. Anybody have any questions or comments? Quiet group today. I will remind you guys that you will have access to the slides as well as the recording of today's video. This will be the first time we will use the iEcho system to send the recap email. We are starting to use that. So it'll have all the same content, everything. It won't say J Mason when it comes to you. It'll say iEcho. So that's the main difference. But just to let you guys know, we are transitioning to using that functionality for the recaps and also the reminder emails. The other thing I will point out is that there is calendar integration now in the system. When you log into your account, you can add the sessions to your calendar, whether it's a Outlook calendar or a Gmail calendar, something like that. You will have to do it for each session. It doesn't have a group option at the moment. That's coming. But just be reminded that it's not going to include the Zoom information. It's basically a placeholder. It's going to hold that timing for your schedule for the Echo, and it's going to point you to the iEcho system to join the session. And that's for security reasons, and everybody has their own Zoom link for each session. It all goes back to privacy and security. That's why they're doing it that way. We understand it's not the most helpful, but at least it can get something on your calendar to hopefully just save the time for you guys, as we know that's an issue. Any other final comments? Go ahead.
I just had a quick comment that I hope we get an opportunity to learn from our participants as well. The longer I practice ID, the more I realize there are many ways to do the same things, to get to the same goals. And sometimes at an institution, you develop a particular approach, and that becomes kind of the way the institution does things. That does not mean there are other ways to do the same thing. So that's where I think the purpose of the Echo for me is also how do other people approach similar scenarios, and what would they do different, and what have their experiences been? And I would appreciate if others share theirs as well.
Well said. Yes, this is not supposed to be grand rounds or anything like that, like where we'll have an hour of lecture or anything like that. So please speak up, ask questions. It doesn't have to be related to the case, or if you just have a question because you're dealing with something, please just feel free to ask or put it in the chat. Send it to us afterwards. We'll bring it up at the next session. We're here to help and to make this for you guys and for the participants. So please let us know. We are at 1 o'clock. If there aren't any other comments or anything like that, we'll adjourn until November 14th. That'll be our next session. All right.
Thank you.
Thank
All right,
you.
take care, everybody.
Bye. Yeah.